Right now, as you're lying there in the dark, something remarkable is happening inside your knee. You're not doing anything. You're not thinking about it. And yet, even completely still, your knee is working. A thin film of fluid, thinner than a sheet of paper, is spread across the ends of your thigh bone and your shin bone, keeping two surfaces of living cartilage from ever quite touching each other, even under your full weight, even after a day of standing, walking, climbing stairs, kneeling down to pick something up off the floor. Somewhere in there, tiny sensors are reporting the angle of the joint back to your spinal cord dozens of times a second without you ever once being aware of the reports being filed. Your knee has been doing this since before you could talk. It will keep doing it tonight. And the reason your knee can do all of this: bear your full weight, bend 130 degrees, absorb the shock of every step you've ever taken, while somehow also being one of the most commonly aching, commonly misunderstood joints in the entire human body. That's one of the strangest stories in all of medicine, but we'll get to that. And if you're here because your knee has been bothering you, you're in the right place. Not because we're going to give you a list of fixes, but because once you actually understand what's going on in there, most of the fear just dissolves. And sometimes that understanding is the thing that needed to happen first. But let's start somewhere closer, right here, in your body, in this moment. So let's look at what's happening in your knee right now. Even as you lie still in the dark, the synovial fluid is circulating slowly through the joint capsule, carried along by the smallest movements you make without noticing. A shift of the leg, a slight bend, a change of position. It's not a passive puddle. It's closer to a living, self-renewing lubricant. And inside it is a molecule called hyaluronic acid, which gives it that slippery, faintly viscous quality. Engineers who study friction, a field called tribology, have pointed out with a certain professional envy that the friction between two surfaces of healthy cartilage, cushioned by this fluid, is lower than ice sliding on ice. It's one of the more elegant pieces of engineering the body has ever produced, and it's happening right now, whether you're aware of it or not. The chondrocytes, the cells responsible for maintaining your cartilage, are continuing their quiet, patient work. And here's the first thing worth correcting immediately, because it shapes almost everything else we're going to talk about tonight. The knee is not a simple hinge, wearing down steadily with use, the way a hinge on an old door wears down with every swing. That's the mental image most of us carry around, and it's an understandable one. It's simple, mechanical, easy to picture, but it's wrong in a way that matters. Cartilage has no blood vessels running through it at all. Instead, it's nourished by the very fluid we just described, absorbing nutrients the way a sponge absorbs water, a process that actually works better with gentle, rhythmic movement than with stillness. This is living tissue. It adapts, it remodels itself slowly in response to the load you place on it, more like muscle responding to training than a tire wearing down on a road. A better image, if you need one, might be a suspension bridge rather than a hinge. A suspension bridge doesn't simply resist load passively, the way a solid block of stone might. It distributes it across cables, across joints designed specifically to flex, across a structure engineered to move slightly under stress rather than remain perfectly rigid. Your knee does something similar. Weight moving through it isn't simply absorbed by two flat bone surfaces grinding against each other. It's distributed across cartilage, across the menisci, across ligaments tensioning and releasing with every step. A whole system working together, each part sharing the load, rather than one surface bearing it alone. Between the femur and the tibia, there are also two crescent-shaped pads of cartilage called the menisci, sitting like cushions inside the joint. For much of the 20th century, these were considered close to disposable, minor padding, removable without real consequence if damaged. That turned out to be one of the more expensive assumptions in the history of orthopedic surgery, and we'll get to exactly why shortly. For now, what matters is this: the meniscus actively distributes the load moving through your knee across a wider surface, protecting the cartilage underneath it. It's not a passive spacer. It's doing real, constant structural work. One of the cables in that suspension bridge, not simply a cushion tucked in as an afterthought. Not every meniscus tear behaves the same way, which is worth knowing because the phrase itself tends to get used as though it describes one single uniform injury. A radial tear cuts across the width of the meniscus like a slice through a crescent moon. A horizontal tear splits the tissue into an upper and lower layer, more like separating two pages of a book. A bucket-handle tear is a larger, longer tear where a strip of tissue can flip and lodge itself in the middle of the joint, sometimes mechanically blocking the knee from fully straightening. This is one of the few situations where the knee can genuinely lock. A real mechanical block rather than pain simply making the joint feel stiff and reluctant to move. That distinction matters clinically because a true mechanical lock, where the knee physically cannot extend a certain amount no matter how gently you try, is a different situation from the much more common experience of a knee that feels stiff, guarded, or reluctant to move fully because of pain, swelling, or muscle guarding, even though from the inside, in the moment, both can feel remarkably similar. Where exactly a meniscus tear sits also matters enormously for how well it can heal, which connects directly back to that lack of blood supply we discussed earlier. Surgeons often describe the meniscus in terms of zones. The outer edge, closest to the joint capsule, does have some blood supply and is sometimes called the red zone, capable of genuine healing given the right conditions. The innermost portion has essentially none at all, sometimes called the white zone, and tears there have very limited capacity to heal on their own regardless of treatment. Between the two sits a red-white zone with partial blood supply and correspondingly partial healing potential. This zonal reality is a large part of why some meniscus tears are realistically repairable, and others, however small, simply aren't. Not because of anything a patient did or didn't do, but because of exactly where, geographically, inside a structure with famously uneven blood supply, the tear happens to sit. There's another commonly misunderstood knee condition worth mentioning briefly here. Simply because people often assume any knee swelling means the joint itself is damaged. Bursitis, an irritation of one of the small fluid-filled sacs called bursae that cushion areas where skin, tendon, or muscle would otherwise rub directly against bone. The bursa at the front of the kneecap, when irritated, produces a very recognizable, often dramatic-looking swelling, historically nicknamed housemaid's knee, after the repeated kneeling once common in domestic work. Though it shows up today in gardeners, tilers, and anyone spending long periods on their knees, it can look alarming. A swollen balloon sitting visibly at the front of the joint, and yet it's a problem with a small, superficial cushion, not with the joint's own internal structures at all. A useful reminder that not every swelling around the knee means the same thing, or carries the same significance. Now here's the part that matters most if your knee has actually been bothering you. What is pain, mechanically speaking, and why doesn't it behave the way most of us assume? Pain is not a simple readout of tissue damage, arriving from the knee to the brain like a fire alarm wired directly to a smoke detector. What actually happens is closer to this. Specialized nerve endings in the joint, called nociceptors, detect potentially threatening signals, mechanical pressure, inflammation, chemical changes, and send that information up to the spinal cord and brain. But whether that signal is ultimately experienced as pain and how intense that pain feels depends on an enormous amount of additional processing along the way. Inflammation levels, muscle tension around the joint, prior experience with pain in that same area, expectation, attention, stress, sleep quality. Two knees with nearly identical tissue findings can produce completely different pain experiences because the nervous system interpreting the signal is doing so much more than simply relaying a damage report. This is part of why knee pain can persist even after a scan comes back looking essentially normal, and why some genuinely striking findings on a scan, a torn meniscus, some cartilage thinning, show up routinely in the knees of people who report no pain at all. We'll come back to exactly how often that happens because the numbers are more surprising than most people expect. For now, the important thing to hold on to is this: a scan finding and a pain experience are related, but they are not the same thing. And confusing the two is one of the more common sources of unnecessary fear around this joint. There's another detail worth including here because it surprises almost everyone who hears it for the first time. A significant proportion of knee pain doesn't actually originate in the knee at all. The hip joint and the muscles surrounding it share enough nerve pathways with the knee that hip problems can produce pain that's felt distinctly in and around the knee, sometimes with no hip symptoms noticed whatsoever. This is called referred pain, and it's part of why a thorough assessment of knee pain very often includes a careful look at the hip and the lower back too, rather than treating the knee as a joint working in isolation. And remember those tiny sensors we mentioned at the very beginning, reporting the angle of your knee back to your spinal cord without you noticing? That sense is called proprioception, the body's ability to know where it is in space without needing to look. And it depends heavily on nerve endings embedded directly inside the ligaments of the knee. This is part of why an injury to a ligament affects far more than simple mechanical stability. It genuinely, if often temporarily, degrades the joint's built-in sense of itself. There's one more piece of the mechanism worth understanding tonight because it explains a very common kind of ache, the pain felt specifically at the front of the knee, often worse, on stairs or after sitting a long time. The kneecap, or patella, sits inside the tendon of the large quadriceps muscle group, running down the front of your thigh, like a small round stone embedded in a strap. Its position and tracking as the knee bends depend heavily on how evenly the surrounding muscles are firing. Even a short period of reduced activity, from injury, illness, or simply a sedentary stretch of life, can quietly weaken or unbalance those muscles, changing how force moves through that tendon and the joint underneath it. It's one of the more common and more correctable contributors to that specific kind of ache, because muscle, unlike cartilage, responds and adapts relatively quickly to how it's used. There's also a specific sensation worth explaining, because it tends to alarm people more than almost any other knee symptom: the feeling of the knee suddenly, briefly, giving way as though it might buckle entirely even without an actual fall. This can have several different underlying causes, and they're worth distinguishing, if only briefly, because they carry very different implications. Sometimes it reflects a genuine, if momentary, mechanical instability, the kind that can follow a significant ligament injury. But very often, especially in the absence of any specific injury, it reflects something considerably less alarming: a sudden reflexive inhibition of the quadriceps muscle, sometimes triggered by pain itself, sometimes by swelling within the joint pressing on nearby nerve receptors, causing the muscle to briefly, involuntarily reduce its output rather than the joint's actual structure failing. The sensation feels dramatic and frightening in the moment. The underlying mechanism, in a great many cases, is a muscle temporarily forgetting to fire at full strength, not a joint about to collapse. There's one more structure inside the joint worth a brief mention, mostly because it's so often overlooked entirely: the synovial plica, a fold of the joint lining left over from early fetal development, present to some degree in most people's knees without causing any trouble at all. In a smaller number of people, this fold can become irritated or thickened, catching slightly during movement and producing a clicking sensation or localized ache, particularly at the inner side of the kneecap, a condition sometimes called plica syndrome. It's a useful example of something worth remembering throughout tonight. The knee contains structures most people have never heard of, doing quiet background work or occasionally causing minor trouble, entirely separate from the more commonly discussed cartilage, ligaments, and menisci, which is part of why a single confident label rarely captures everything that could plausibly be happening inside a joint this intricate. So here is a more accurate picture to carry forward. Your knee is not a hinge slowly wearing out. It's a living, fluid-lubricated, load-distributing structure, wired into a nervous system that interprets its signals through an enormous amount of context, connected to the hip above it, monitored by sensors inside its own ligaments, and capable of adapting to demand rather than simply depleting under it. There's a broader piece of context worth sitting with here too, one that reframes the whole conversation slightly. The human knee is, in evolutionary terms, a genuinely unusual structure. Most mammals distribute their weight across 4 limbs, and their knee-equivalent joints are built for that arrangement. Somewhere around 6 or 7 million years ago, our ancestors began shifting toward walking upright on 2 legs, and the knee had to be re-engineered over an enormous span of evolutionary time to bear the entire weight of the body, absorb impact with every single step, and do it all while balancing directly over a single narrow base rather than 4 spread points of contact. Anthropologists who study the fossil record can actually trace this shift by looking at the angle of the femur alone, the degree to which it angles inward toward the knee, called the carrying angle, is one of the clearest skeletal markers separating bipedal ancestors from their quadrupedal predecessors. Every time your knee absorbs the shock of a single step, it's performing a piece of biomechanical engineering that took millions of years of gradual adjustment to make possible, and that most other mammals on the planet simply don't need their joints to do in the same way. That evolutionary history also explains something about why knee problems are so extraordinarily common compared to, say, problems with the elbow or the wrist. The knee sits at the center of an enormous amount of load and torque, absorbing not just straight-ahead impact, but also the twisting, pivoting, sidestepping forces involved in nearly everything we do standing upright, walking on uneven ground, turning to reach for something, climbing stairs at an angle rather than straight on. It's not that the knee was poorly designed. It's that it was asked, relatively recently in evolutionary terms, to do an extraordinarily demanding job that most of the mammalian body plan hadn't originally accounted for, and it's done a genuinely remarkable job of adapting to that demand. There's also meaningful variation in how different knee problems show up across different groups of people, worth knowing simply because it corrects another common oversimplification: the idea that knee pain is one single thing happening to everyone in the same way. Anterior cruciate ligament tears, for instance, occur at meaningfully higher rates in female athletes than male athletes participating in the same pivoting sports, a difference researchers attribute to a combination of factors, including the angle at which the thigh bone meets the shin bone, sometimes called the Q angle, differences in hormonal fluctuation across the menstrual cycle affecting ligament laxity, and differences in typical landing and movement mechanics that appear, at least partly, to be trainable rather than fixed. Osteoarthritis, by contrast, becomes increasingly common with age in both sexes, but shows somewhat different patterns of onset and severity between men and women after midlife, an area of research still actively being refined. None of this means one group's knee is simply weaker or more prone to failure. It means the knee's story plays out somewhat differently, depending on hormones, mechanics, and history. In ways researchers are still working to fully map out. If that's the more accurate picture, why does almost nobody talk about the knee this way? Why do we still hear wear and tear, bone on bone? It's just age. Everywhere we turn, that's worth understanding too. And it takes us somewhere unexpected. So, if the knee isn't a simple hinge wearing out, why do we still hear that everywhere? Where did that idea come from? And why has it been so hard to replace? It's worth noting, before we even get to Galen, that this wasn't a case of nobody paying careful attention. In ancient Greece, Hippocrates, working around 460 BCE, described joint pain with a level of clinical detail that still reads as recognizable today, including what sounds very much like a dislocated kneecap and a method for manipulating it back into place, and what sounds very much like a fluid-filled swelling behind the knee. Though he had no framework for explaining why fluid would accumulate there, in India, roughly the same period, a physician-surgeon named Sushruta described a joint disorder in the Sushruta Samhita with symptoms, pain, swelling, a grinding sensation with movement, specific enough that many modern readers recognize it immediately as osteoarthritis, arrived at through an entirely different theoretical system built around disturbed bodily principles, rather than anything resembling Greek humoral theory. And in ancient China, joint pain was understood through the framework of blocked or disrupted flow moving through channels passing through the joint, treated with manual manipulation, and, eventually, acupuncture. 3 separate civilizations, no meaningful contact between them, arriving independently at the observation that joint pain isn't one single thing, and that different presentations call for different responses. The careful watching was there, everywhere, remarkably early. What was missing, everywhere, was an accurate map of what was actually happening underneath the skin. The story of that map starts, oddly enough, with a ban. In ancient Rome, a Greek physician named Galen, born around 129 CE, was forbidden by law from dissecting human bodies. So he dissected animals instead: pigs, dogs, and most influentially, Barbary macaque monkeys, which he had unusually good access to. Monkey knees and human knees are similar, but not identical. The angles differ. The way the kneecap sits differs. The geometry of how the joint bears weight walking upright is subtly but meaningfully different. Galen wrote it all down as human anatomy anyway, and because he was brilliant, prolific, and extremely confident, his writings became close to medical scripture for the next 1400 years. That made sense for his time. Dissection was banned, and animal anatomy was the best available substitute. But it meant that, for well over a millennium, the actual internal architecture of the human knee, the ligaments, the menisci, the true cartilage geometry, simply wasn't accurately known. It took a stubborn 28-year-old Flemish anatomist named Andreas Vesalius in 1543 actually dissecting human bodies rather than inherited animal ones to finally correct the record. As a student, he reportedly retrieved bodies of executed criminals from gallows outside city walls at night, sometimes fighting off dogs to do it, simply to have material to study. He mapped the real shape of the joint, the real ligaments, the real geometry, and it cost him. His own former teacher in Paris, a committed Galenist named Jacobus Silvius, became one of his fiercest public critics, reportedly suggesting, rather than accept, that Galen could simply be wrong, that the human body itself must have changed shape since antiquity. Vesalius was accused of arrogance, of undermining 1,000 years of accepted wisdom, and he eventually left academic anatomy altogether. But the anatomical picture, at least, was finally accurate. Notice, though, that Galen's error had already traveled a very long way before Vesalius caught up with it. A physician named Avicenna, writing in Persia around 1000 CE, inherited Galen's framework wholesale and built one of the most influential medical textbooks in history on top of it, the Canon of Medicine, used as the standard reference across the Islamic world and, in translation, European universities for roughly 600 years. Avicenna added enormously careful clinical observation of his own, distinguishing joint pain that worsened with movement from joint pain that came with heat and swelling, a genuinely useful diagnostic instinct. But the underlying anatomical foundation stayed exactly as wrong as Galen had left it, simply because nobody thought to question a foundation that 6 centuries of careful, intelligent physicians had already built so much on top of. That's worth sitting with for a second. The more elaborate and rigorous a system built on a wrong foundation becomes, the harder that foundation is to question, precisely because everything above it looks so solid. The problem is, an accurate map of the parts doesn't automatically produce an accurate understanding of how the whole thing behaves. And that's where the next layer of misunderstanding crept in. This time, from a completely different direction. Imaging technology. In November of 1895, a physicist named Wilhelm Röntgen was experimenting with cathode ray tubes in a laboratory in Würzburg, Germany, when he noticed a faint glow coming from a screen across the room, a glow that persisted even when the tube was covered in black cardboard, meaning something was passing through solid material that shouldn't have been able to. He spent the following weeks testing the mysterious rays against wood, rubber, aluminum, and eventually, in a now legendary moment, his own wife's hand placed between the ray source and a photographic plate. The image showed her bones clearly, including her wedding ring floating around a finger made of visible skeleton. She reportedly said she had seen her own death, a dramatic reaction, but an understandable one for the first person in history to see the inside of her own living body without being cut open. For the first time, physicians could see inside a joint without any surgery at all. It was a genuine revolution, but the X-ray could only see bone. It was completely blind to cartilage, ligament, meniscus, and fluid, to virtually everything inside the knee that isn't calcium. For nearly a century, this meant physicians were diagnosing knee problems by looking at one part of the joint and inferring the rest. And because bone changes, the narrowing of joint space, bony growths at the edges were the only visible sign of trouble. Wear and tear language, built entirely around what the bone looked like, became the dominant framework. Doctors weren't being careless. They were doing the best they could with a tool that showed them half the picture and let them assume the rest. That bone-only framework also flattened something important: the fact that arthritis was never really one single condition. An English physician named William Heberden had already, back in 1802, carefully distinguished degenerative joint changes from gout, a separate condition involving crystal deposits, well understood even in antiquity. But the X-ray era, with its narrow, bone-focused view, made it easy for the broader public, and even some clinicians, to lump every kind of joint deterioration together under one vague umbrella. In reality, osteoarthritis, the gradual, mechanically and biologically driven degeneration we've been discussing tonight, is a fundamentally different process from rheumatoid arthritis, an autoimmune condition in which the body's own immune system mistakenly attacks the joint lining, or post-traumatic arthritis, which develops specifically following a significant injury, like a fracture or ligament tear, sometimes years afterward. Each involves different underlying biology, different typical ages of onset, and different patterns of which joints are affected, and how symmetrically. A bone-only image showing only the downstream skeletal consequences could never have distinguished between them clearly on its own. Another quiet way, a single, limited technology shaped decades of oversimplified public understanding. This is when the meniscus mistake enters the story properly. Through much of the 20th century, surgeons believed the meniscus was, at best, a passive cushion, removable if torn, without much consequence. Total meniscectomy, removing the whole structure, was routine for decades. It took a surgeon named T.G. Fairbank in 1948, tracking patients for years after the surgery, rather than weeks, to show that removing the meniscus entirely dramatically accelerated arthritis in that knee, because it hadn't been a passive pad at all. It had been distributing load, protecting the cartilage underneath it. An entire generation of surgery had been built on an assumption nobody had bothered to test over a long enough time frame. Popular orthopedic textbooks through the early and mid-20th century compounded this effect further, translating the bone-only imaging picture into confident, standardized language taught to generations of medical students. Phrases describing joint space narrowing and osteophyte formation as markers of a single, linear disease process. Presented with a clinical certainty the underlying science didn't yet fully support, students trained on this language carried it forward into their own careers and their own patient conversations for decades, which is part of why phrases like wear and tear and bone on bone, coined to describe a bone-centered X-ray finding in a textbook nearly a century ago, still surface so readily in ordinary conversation about knee pain today, largely unchanged, even as the underlying science describing the joint has moved considerably further along. The early 20th century also introduced a very different, non-medical pressure that quietly reinforced the mechanical, wear and tear story: industrial compensation systems. As workers' compensation and disability insurance schemes expanded across Europe and North America through the early 1900s, physicians were increasingly asked, in a formal legal capacity, to assess whether a worker's knee problem was caused by their occupation and to what degree it impaired their ability to work. This created a genuine institutional incentive to describe knee conditions in simple, mechanical, quantifiable terms: degrees of wear, percentages of disability, clear cause, and clear consequence. Because that was the language insurance systems and courts needed to process a claim. A framework built for legal and administrative clarity isn't necessarily the same framework that best describes the actual underlying biology. But once that language became embedded in medical, legal, and insurance documentation for decades, it became considerably harder to dislodge, simply because so many institutions had built their processes around it. There's a practical reason surgical correction of the knee took so long to develop into a real option at all, worth mentioning here, because it explains why rest and wait remained close to the only realistic path for so many centuries, before general anesthesia became reliably available. Starting with the famous 1846 public demonstration of ether at Massachusetts General Hospital, any operation on a joint as deep and complex as the knee was an agonizing, high-risk undertaking, performed quickly and crudely on a fully conscious, restrained patient, with infection afterward posing an enormous additional risk given the complete absence of antiseptic technique until the work of Joseph Lister in the 1860s. Under those conditions, opening a knee joint surgically to investigate or repair internal damage simply wasn't a realistic option for the overwhelming majority of patients, no matter how well anatomists like Vesalius had already mapped the structures involved. Conservative management, rest, splinting, waiting wasn't only a matter of incomplete biological understanding. For centuries, it was often the only genuinely survivable option available, which helps explain why an instinct towards stillness became so deeply embedded in how joint injuries were approached, long before anyone had gathered evidence about whether stillness actually served the healing joint well. And there's one more thread that reinforced all of this, arriving from a completely different corner of medicine: the culture of rest. For decades, the standard advice for almost any joint injury was built around the acronym RICE: rest, ice, compression, elevation, coined by an American physician named Gabe Merkin in 1978. Merkin himself later revisited his own advice, pointing to research suggesting that ice and prolonged rest may actually slow parts of the body's natural healing response rather than protect it. But by the time that revision arrived, decades of patients and decades of doctors had already absorbed a simple, intuitive lesson: an aching joint means stop moving it. That instinct, protect a hurting joint through stillness, actually runs deeper than Merkin's 1978 acronym. It echoes a much older tension in how joint problems were handled at all. Alongside university-trained physicians, medieval and early modern Europe relied heavily on bone setters, tradespeople often outside the formal medical establishment, who manipulated injured joints by hand. Skill passed down through families rather than textbooks, physicians of the era frequently dismissed them as unlearned. But the very existence of two separate traditions, one theoretical and cautious, one hands-on and practical, meant joint care had, for centuries, oscillated between two instincts: rest and protect, or manipulate and mobilize, with very little rigorous evidence settling which instinct actually served a given injury better. By the time the word orthopedics itself was coined, in 1741, by a French physician named Nicolas André, the dominant image attached to the entire field was, tellingly, a young tree tied to a straight stake, correction through rigid support, not movement. That image became the literal symbol of orthopedic associations in multiple countries, and it's not hard to see how a field founded on an image of rigid, stake-like correction leaned naturally toward advising rest over motion for the following 2 centuries. Combined with a bone-only view of the joint and a meniscus considered disposable, the picture that emerged was almost inevitable: a mechanical part wearing down, best protected by moving it as little as possible. And then, starting around the 1980s, things began to shift. Quietly at first, in research labs and pain clinics, a different picture started to emerge, one built not on bone alone, but on the entire joint, and not on tissue alone, but on the nervous system interpreting it. That shift became possible largely because of a single technology: magnetic resonance imaging, developed through the 1970s and clinically available by the early 1980s. For the first time in the history of medicine, physicians could see soft tissue, cartilage, ligament, meniscus, fluid without any surgery at all. And once researchers had MRI machines available widely enough to scan large numbers of ordinary people, not just patients complaining of pain, the results quietly unsettled a century of assumptions. Multiple studies through the 2000s and 2010s scanned the knees of people with no pain whatsoever and found meniscus tears in a striking proportion of them. In some studies, more than a third of pain-free adults over 50, climbing higher with age, cartilage thinning, mild arthritic changes, all found routinely in knees attached to people who had no idea anything was different about their joint at all. Think about what that means for a second. It means a meniscus tear, sitting on its own on an MRI report, tells you remarkably little about whether that particular knee actually hurts. Much of this large-scale evidence comes from an enormous, long-running research effort called the Osteoarthritis Initiative, launched in 2002 with funding from the U.S. National Institutes of Health, which has tracked several thousand participants for well over a decade, collecting repeated imaging, clinical exams, and detailed symptom reports along the way. It's the kind of study that simply wasn't possible before MRI became widely available and affordable enough to scan thousands of ordinary volunteers repeatedly over many years. And it has become one of the single richest sources of data on how knee structure and knee symptoms actually relate to each other over time, rather than in a single isolated snapshot. Much of what researchers now understand about the surprisingly loose relationship between imaging findings and reported pain traces back, at least in part, to data gathered through exactly this kind of patient. Long-term observation, a modern, technologically enabled echo of the same patient watching that Hippocrates was doing with far simpler tools 24 centuries earlier. This connects directly to something we touched on a moment ago, the distinction between nociception and pain. Nociception is the raw signal generated by those nerve endings detecting mechanical or chemical threat. Pain is what the brain ultimately produces after processing that signal alongside everything else it has access to: inflammation, expectation, attention, mood, prior experience. In 1965, two researchers, Ronald Melzack and Patrick Wall, proposed gait control theory, arguing that the spinal cord contains something like a gating mechanism, capable of amplifying or dampening pain signals depending on other simultaneous nerve activity, part of why rubbing a bumped knee genuinely does reduce the pain slightly. A decade later, a psychiatrist named George Engel proposed the biopsychosocial model, arguing that any pain condition needs to be understood through biological, psychological, and social factors, together, not biology alone. Both ideas faced real resistance at the time, not unlike the resistance Vesalius faced centuries earlier, but both are now foundational to how modern pain science understands a joint like the knee. There's a related concept called central sensitization, and it's worth understanding clearly because it explains something that confuses a lot of people. When a joint experiences pain over an extended period, the nervous system pathways carrying that signal can actually become more sensitive over time, amplifying input that would once have registered as minor discomfort into something registering as real pain. This is why chronic knee pain can sometimes persist or even worsen, even as the underlying tissue is healing. The volume dial on the pain system itself has been turned up somewhat independently of what's actually happening in the joint. This isn't a claim that the pain is somehow imagined. The amplification is entirely physical, entirely measurable. It simply means a hurting knee is never a story about tissue alone. It's worth returning, too, to that referred pain we mentioned earlier. Pain felt in the knee that actually originates in the hip. Modern imaging and nerve mapping research have clarified why this happens. The femoral and obturator nerves, which supply sensation to parts of the hip joint, also send branches down toward the knee, and the brain, receiving signals along these shared pathways, doesn't always locate the source with perfect precision. This is exactly why a thorough modern assessment of persistent knee pain done properly very often includes the hip and lower back as well, treating the whole lower limb as one interconnected system rather than a chain of separate, independently functioning joints. There's an interesting piece of cross-cultural epidemiology worth including here too, because it complicates the simple story of joints wearing out with use. Populations where deep squatting is a routine part of daily life, used for resting, working, or using the toilet rather than sitting in chairs, place the knee through a dramatically larger range of motion, thousands of times a day, across a lifetime, than populations built around chair-sitting furniture. If the simple wear and tear model were the whole story, we might expect squatting heavy populations to show dramatically higher rates of knee osteoarthritis. The actual epidemiological picture is considerably more mixed than that clean prediction. Some studies do find higher rates of certain patterns of joint degeneration in populations with very high squatting frequency, but the relationship is nowhere near as strong or as simple as pure cumulative mileage would predict, and it's tangled up with other variables entirely unrelated to joint mechanics, including differences in body weight, occupation, genetics, and access to healthcare and diagnosis in the first place. It's a useful reminder that even something as seemingly straightforward as more knee bending equals more wear turns out to be a considerably more tangled question once researchers actually go looking for the answer across different populations. There's also a genetic dimension worth mentioning, because it surprises people who assume joint pain is purely a matter of use or age. Twin studies comparing identical to non-identical twins have found that somewhere between roughly 40 and 60% of the variation in who develops knee osteoarthritis appears to be attributable to inherited factors, cartilage composition, joint alignment, how the body's inflammatory processes behave. Lifestyle and loading history clearly matter too. Throughout everything we've discussed tonight, but two people can live remarkably similar lives and still end up with meaningfully different knees decades later, for reasons neither of them had any control over. Modern research on ligament injury has also deepened what we understand about that proprioceptive sense we mentioned earlier, the joint's built-in awareness of its own position. Studies following patients after an ACL tear have found measurable, if often temporary, deficits in that positional awareness, distinct from and in addition to any loss of mechanical stability. This is part of why modern rehabilitation for a significant ligament injury spends considerable time on balance and control work, not simply on rebuilding raw strength. The joint isn't only relearning how to move, it's relearning how to sense itself, and that sensing turns out to matter for how well it functions afterward. That research into expectation deserves a proper name here, because we've been circling it all night without quite labeling it. The nocebo effect, the lesser-known sibling of the placebo effect, where a placebo describes a genuine, measurable improvement produced by positive expectation alone. A nocebo effect describes the reverse, genuine, measurable worsening produced by negative expectation, frightening information, or the anticipation of harm. Multiple studies on osteoarthritis and chronic pain have documented nocebo effects clearly, including the finding we mentioned a moment ago about alarming diagnostic language increasing reported pain and reducing function over time? It's not a claim that the worsening isn't real. It's a demonstration that the nervous system's response to a joint problem is shaped in a measurable physical way by the story it's been told about that problem, which is precisely why so much of tonight has been spent trying to tell a more accurate one. Modern physiotherapy assessment has, in recent decades, formally incorporated this understanding through a framework sometimes called yellow flags, psychological and social factors, distinct from the purely structural ones that research has shown meaningfully predict how someone's pain is likely to develop over time. Things like high levels of fear about movement, catastrophic thinking about what a diagnosis means, low confidence in one's own ability to influence the outcome, and significant life stress unrelated to the joint itself have all been shown, across numerous studies, to meaningfully affect pain trajectories, sometimes as strongly as structural findings do. This isn't a suggestion that psychological factors cause the pain in some dismissive sense. It's a recognition, built directly on the biopsychosocial model we discussed earlier, that a complete picture of anyone's knee pain includes these factors as genuine, measurable contributors, not as an afterthought tacked onto the real, purely mechanical explanation. There's also active research into pain itself at a molecular level worth mentioning, because it represents one of the newer frontiers in this field, a molecule called nerve growth factor, discovered decades ago but only recently understood to play a significant role in sensitizing pain pathways, specifically in osteoarthritic joints, has become the target of a newer generation of medications designed to block its activity directly, offering pain relief through an entirely different mechanism than traditional anti-inflammatory drugs. Early trials have shown genuine promise for some patients, alongside some safety concerns that researchers are still working through. A live example of a piece of the puzzle that is, right now, still being actively debated, rather than a settled matter from decades past. And there's a related piece of this puzzle. Researchers are still actively debating, too, exactly how durable newer cartilage regeneration techniques prove to be over many years. Since the 1990s, procedures like autologous chondrocyte implantation, growing a patient's own cartilage cells in a lab and reimplanting them, and more recently, stem cell approaches, have aimed at genuinely regenerating damaged cartilage rather than simply managing its decline. Results are promising in some cases, mixed in others, and the long-term durability question remains open. What's changed is the underlying ambition. For most of this joint's history, cartilage loss was assumed to be a one-way road, active pursuit of genuine regeneration, however incomplete so far, is a meaningfully different relationship with the tissue than anything that came before. Perhaps the single most unsettling piece of modern research on the knee, though, came from a 2002 trial led by a surgeon named J. Bruce Moseley, examining arthroscopic surgery for osteoarthritis, a procedure that, at the time, was performed on hundreds of thousands of patients a year, generally involving washing out the joint and smoothing damaged cartilage surfaces. Moseley's trial did something almost unheard of in surgical research. It included a genuine placebo group. Patients in this group were taken to the operating room, given anesthesia, and received the standard 3 small incisions on the skin, but no actual surgery was performed inside the joint at all. Neither the patients nor the physicians assessing their recovery afterward knew who had received real surgery and who had received the sham procedure. The results, published in the New England Journal of Medicine, found that patients in the placebo group reported improvements in pain and function statistically indistinguishable from those who received the real surgery. The finding was, understandably, controversial, And it doesn't mean surgery never helps for more specific structural problems, but for that particular procedure, in that particular condition, it was a genuinely humbling demonstration of how much of a treatment's apparent benefit can come from expectation, attention, and the ritual of care itself, rather than the specific mechanical intervention performed. A related, smaller example of the same pattern involves glucosamine and chondroitin, two supplements marketed for decades specifically for joint health, based on the reasonable-sounding idea that supplying the raw building blocks of cartilage orally might help maintain it. Large, well-designed trials through the 2000s and 2010s, including a major study funded by the U.S. National Institutes of Health, found effects on pain that were, at best, and in many analyses, statistically indistinguishable from placebo for the broader population, though a subset of patients with more moderate to severe pain showed some benefit in certain trials. The science here remains genuinely mixed rather than fully settled, but it's another instance of the same underlying lesson. Intuitive, mechanically appealing explanations for what helps a joint don't always survive rigorous testing, and the only way to know which ones do is to actually test them carefully, the way Moseley did, rather than trusting how sensible an explanation sounds on its own. It's worth understanding briefly what cartilage is actually made of, because it explains why it behaves so specifically the way it does. The framework holding it together is built largely from a specific protein called type 2 collagen, arranged in a dense mesh that gives cartilage its distinctive combination of firmness and flexibility, embedded within a gel-like matrix that helps it resist compression. Researchers have identified breakdown fragments of this exact collagen type circulating in the blood and joint fluid of people with osteoarthritis, and measuring these fragments alongside inflammatory markers like interleukin-6 and C-reactive protein has become an active area of research aimed at eventually predicting, through a simple blood test, which knees are likely to progress toward more significant degeneration before that progression becomes visible on any scan at all. This kind of biomarker research remains, honestly, some distance from routine clinical use, but it represents a meaningfully different approach than anything available for most of this 3,500-year story. Moving from waiting to see visible structural change toward potentially detecting the earliest biological signs of trouble long before it becomes symptomatic. Technology has also changed how researchers observe the knee in motion, not just in static images. Modern gait analysis laboratories, using multiple cameras and force-sensitive floor plates, can measure precisely how load moves through a walking knee at each fraction of a second, and wearable sensors, small enough to attach directly to clothing or skin. Now, let researchers collect this kind of movement data over days or weeks of ordinary life rather than a single short lab visit. This has revealed considerable variation in how differently people distribute load through an aching knee without any conscious awareness of doing so. Subtle shifts in gait that develop, often unconsciously, as a kind of protective adaptation, sometimes helpful in the short term, and sometimes, over a longer period, placing new and different strain elsewhere in the leg. It's one more layer of the interconnected picture we've built tonight. A knee's behavior can quietly reshape how the hip, the ankle, and the opposite leg are all being used too. Long-term imaging data, collected through studies like the one we mentioned a moment ago, has also clarified something worth knowing simply because it corrects an overly dramatic mental image many people carry. Cartilage loss in osteoarthritis, measured precisely across repeated scans over years, tends to progress considerably more slowly and more unevenly than the phrase wearing away tends to suggest. Some knees show measurable thinning over a decade, Others, followed just as carefully, show remarkably little measurable change over the same span, despite ongoing symptoms. It's a slow, uneven, individually variable process, not a steadily ticking countdown running at the same pace in every knee. There's a useful framework developed by a surgeon named Scott Dye in the late 1990s, sometimes called the envelope of function. Worth mentioning here because it captures something the pure structural model misses entirely. Dye proposed thinking of each joint as having a range of loads it can comfortably tolerate at any given time. An envelope that can expand with appropriate progressive loading, the way capacity builds with training, or contract during periods of injury, illness, deconditioning, or even significant life stress. Pain, in this model, often signals that a particular activity has exceeded the joint's current envelope at this particular moment, not necessarily that the joint is structurally failing. The envelope itself is dynamic, not fixed, which reframes the entire question away from "is my knee damaged?" and towards something closer to "what is my knee currently prepared for?" and "how do I help that capacity grow?" It's a subtle shift in framing, but it moves the conversation away from a static, binary sense of a joint being either broken or fine, towards something considerably more accurate to how these tissues actually behave over time. It's also worth knowing that how a given knee problem gets treated varies considerably depending on where in the world and even which specific clinic a person happens to seek care, a detail that quietly undermines the idea that treatment decisions flow purely and directly from biological necessity. Rates of knee arthroscopy, meniscus surgery, and even total knee replacement differ substantially between countries with broadly similar populations and broadly similar rates of underlying joint disease, shaped as much by differences in healthcare systems, reimbursement structures, specialist availability, and local medical culture as by anything happening differently inside the joints themselves. This isn't a claim that surgical decisions are arbitrary. Genuine clinical judgment and genuine structural findings both matter enormously in any individual case. It's simply a reminder that the path from "here is what the tissue looks like" to "here is what should be done about it" runs through considerably more human, institutional, and cultural terrain than the purely mechanical model of the knee ever accounted for. So what does all of this mean for us, practically, personally, in our daily lives? So what do we do with all of this? Let's start with the myth this whole story keeps circling back to: bone on bone, or the knees of someone 20 years older, or the idea that cartilage is simply wearing away with nothing to be done but wait for it to worsen. Osteoarthritis, the most common cause of chronic knee pain, is now understood as a considerably more active, more dynamic process than the old, tire-wearing-down model suggests, involving low-grade inflammation, changes in the bone underneath the cartilage, and a genuine biological attempt at repair happening alongside the degeneration, not simply passive erosion. That inflammation deserves a slightly closer look because it connects two things that sound, at first, like they should contradict each other: inflammation as part of the problem and movement as part of the solution. The joint lining, called the synovium, is where much of this low-grade inflammatory activity actually originates, releasing signaling molecules that can sensitize nearby nerve endings and contribute to the sense of aching stiffness, particularly after a period of rest. And yet, moderate, regular exercise has been shown across a substantial body of research to produce its own systemic anti-inflammatory effect over time, not by eliminating inflammation entirely, which serves genuinely important protective and repair functions, but by improving the body's regulation of it, reducing the kind of chronic, low-grade background inflammation associated with a sedentary state. It's a genuinely counterintuitive finding for anyone holding on to the idea that a joint with inflammation needs stillness above all else. In many cases, appropriately dosed movement appears to calm the same inflammatory processes that stillness was long assumed to protect. This connects to one of the more persistent fears worth addressing directly, that movement and exercise accelerate a knee's decline, and that rest protects it. The evidence runs in large part the other way. It's worth noting, though, that this doesn't swing the pendulum all the way to the opposite extreme either. The old no pain, no gain instinct, pushing hard through sharp or escalating pain in the belief that discomfort itself is a sign of productive progress, has its own well-documented problems, often flaring symptoms and eroding confidence rather than building genuine capacity. The more accurate picture, supported by a considerable body of modern rehabilitation research, sits between those two extremes, something researchers often call graded exposure or graded loading, gradually and systematically increasing what a joint is asked to do in small enough steps that the tissue and the nervous system both have room to adapt, rather than either avoiding all discomfort indefinitely or overwhelming the system all at once. It's a considerably less dramatic story than either extreme, neither rest completely nor push through the pain, but it's the one the evidence most consistently supports. There's a principle from the 1890s named after a German anatomist called Julius Wolff, sometimes called Wolff's Law, describing how bone continuously remodels itself in response to the mechanical load placed on it, growing denser and stronger along the lines of stress it regularly experiences, and gradually losing density where load is removed. The same general principle of adaptive remodeling, refined considerably by more recent research, appears to apply to varying degrees across the connective tissues of the knee as well, tendon, and to a real but more limited extent, given its lack of blood supply, even cartilage itself. Long-term studies tracking recreational runners have found rates of knee osteoarthritis that are, if anything, somewhat lower than in sedentary populations. A study led by researcher Jeffrey Katz in 2013 took patients over 45 with a common type of degenerative meniscus tear and compared surgery to supervised physical therapy alone. 6 months later, both groups reported essentially the same improvement. A Danish program called GLAD put tens of thousands of patients with knee and hip osteoarthritis through structured education and exercise rather than defaulting straight to medication or surgery, and documented consistent, meaningful reductions in pain across the population. None of this means every knee is fine or that surgery never helps. Some tears, some ligament ruptures, some end-stage arthritis genuinely need it. But for a great many people, the belief that a hurting knee must be protected through stillness simply doesn't match what the tissue itself seems to need. It's worth mentioning briefly, too, that this same relationship between loading and adaptation shows up early, in a form most people encounter without ever connecting it to the rest of this story. Growing pains around the knee in adolescence, often diagnosed as Osgood-Schlatter disease, a temporary irritation where the patellar tendon attaches to the shin bone, common in young athletes during growth spurts. For decades, this was treated with considerable alarm and often complete rest from sport, based on an assumption that continued activity risked serious permanent damage to the growth plate. More recent understanding frames it as a largely self-limiting, load-related irritation that typically resolves as the growth plate matures, generally managed through modified rather than eliminated activity. It's a smaller scale echo of the exact same pattern we've traced all night. An alarming label, a reflexive instinct toward complete rest, followed by a gradual, evidence-based softening of both. Once researchers actually followed enough young patients over enough years to see how the condition genuinely behaved. A few smaller fears are worth dismantling gently while we're here. The cracking or popping sound a knee sometimes makes, crepitus, clinically, is in the overwhelming majority of cases just gas bubbles shifting in the joint fluid, or tendons moving across bone. It happens in healthy joints and arthritic ones alike, and on its own, it tells you very little. And the old belief that joints predict rain? Controlled studies looking for a real link between weather changes and joint pain have produced remarkably inconsistent results. Likely because memory is very good at noticing the days it rained and the knee ached, and much worse at noticing the many days it rained and nothing happened at all. A few smaller fears are worth dismantling gently while we're here. The cracking or popping sound a knee sometimes makes, crepitus, clinically, is in the overwhelming majority of cases just gas bubbles shifting in the joint fluid, or tendons moving across bone. It happens in healthy joints and arthritic ones alike, and on its own, it tells you very little. And the old belief that joints predict rain, controlled studies looking for a real link between weather changes and joint pain have produced remarkably inconsistent results, likely because memory is very good at noticing the days it rained and the knee ached, and much worse at noticing the many days it rained and nothing happened at all. It's worth mentioning, too, that many of the specific hands-on and equipment-based treatments historically offered for knee pain have gone through their own version of this same reevaluation. Ultrasound therapy, once a near universal fixture of physiotherapy clinics for soft tissue injuries, has seen its evidence base for genuine tissue healing effects narrow considerably under closer scrutiny, even as it may still offer some patients a comforting, warm sensation during a session. Knee braces, similarly, have a genuinely mixed evidence picture. Certain specific designs show real benefit for certain specific structural problems, like unloading one particular compartment of an arthritic joint, but the broad, generic assumption that any brace provides meaningful protective support for any knee turns out not to hold up especially well under controlled testing. None of this means every hands-on or equipment-based treatment is worthless. Some have held up remarkably well under scrutiny, including certain manual therapy techniques and specific exercise-based approaches. It simply means that, exactly as with the joint itself, confident-sounding, mechanically intuitive treatments deserve the same careful testing before being trusted, rather than being assumed effective simply because they feel logical or have been used for a long time. There's a labeling habit worth mentioning too, because it's a smaller, more recent version of the same pattern we traced earlier tonight. For much of the mid-20th century, front of knee pain in younger, often active patients was routinely labeled chondromalacia patellae, literally, softening of the kneecap cartilage, used almost as a catch-all, regardless of the actual underlying cause. Largely because the tools of the time couldn't reliably distinguish between the several genuinely different conditions that produce similar symptoms in that same spot. Modern understanding has split that single label into more specific categories: patellofemoral pain, patellar tendinopathy, fat pad irritation, each with a different underlying mechanism. A confident, single label used for decades, quietly splitting into a more accurate set of distinctions once anyone looked closely enough to tell them apart. It's the same story, told at a smaller scale. That same attention to language has had a genuinely concrete effect on medical practice recently, worth mentioning because the correction is still actively happening now, not safely finished. decades ago. A number of radiology and orthopedic professional bodies have, since the 2010s, revised the standard terminology used in imaging reports for joints like the knee, specifically because words like degeneration, wear, and tear were found to reliably increase patient anxiety even when describing findings that were statistically extremely common and often unrelated to the patient's actual pain. Some clinics now favor calmer, more neutral language for age-related changes in reports meant for patients to read. A small, almost bureaucratic-sounding shift in wording, but given everything we've walked through tonight about how strongly context and expectation shape the felt experience of pain, arguably one of the more consequential corrections happening in this field right now, it's worth addressing body weight too, because it tends to arrive loaded with guilt. Additional weight does increase mechanical load through the knee, and weight loss, where relevant, is associated with real reductions in pain in a number of studies. But the relationship is far less simple than more weight equals proportionally more wear. Some of the most severe arthritis shows up in lean, active people, and some of the mildest in people carrying more weight. It's one variable among the many we've discussed tonight, not a single, simple explanation. And treating it as the whole story tends to add unhelpful self-blame to something considerably more complicated. And it's worth gently addressing joint replacement, the endpoint many people associate with serious knee trouble. It has genuinely transformed lives for people with severe end-stage arthritis. It's also worth knowing that the procedure itself has come an extraordinarily long way in a relatively short time. The very first attempt at replacing a diseased knee joint dates back to 1890, when a German surgeon named Themistocles Gluck tried fixing an artificial joint carved from ivory into place using a cement made of plaster, resin, and pumice, an idea that was, in essence, correct, but roughly 7 decades ahead of the material science and surgical technique needed to make it actually work, and it failed almost universally, usually through infection, given the complete absence of antibiotics at the time. It took until the 1960s and 1970s, with durable metal alloys, medical-grade plastics, and surgeons like John Insall refining the actual design and technique, for total knee replacement to become the reliable, well-established procedure performed many hundreds of thousands of times a year today. Even now, the procedure continues to improve. Implant designs, surgical precision, guided by computer navigation, and post-surgical rehabilitation protocols are all considerably more refined than they were even 20 years ago. But it remains a significant, generally later step, reserved for cases where more conservative approaches have had a fair, sustained trial. For the large number of people earlier on that spectrum, an aching but still largely functional knee, an imaging report that sounds worse in writing than it behaves day to day, replacement sits, for most, considerably further down the road than fear around a new diagnosis often suggests. It's also worth knowing, gently, that a replaced joint is not necessarily permanent in every case. Modern implants typically last well over a decade, often 2, and revision surgery, while less common, does exist as an option if a joint ever needs it, which is worth mentioning simply because it removes some of the finality often attached to the decision in people's minds. There's one more common piece of advice worth examining with the same careful eye. The instruction to simply listen to your body, offered so often, so confidently, that it rarely gets questioned. It's well-intentioned and, in a general sense, genuinely useful. Nobody else can feel what you feel. But given everything we've walked through tonight about central sensitization, About the gap between scan findings and actual pain? About fear itself amplifying the felt experience of movement? Listening to your body turns out to be a considerably less straightforward instruction than it first appears. A sensitized nervous system can produce loud, insistent pain signals in response to movement that poses no genuine risk at all, which means the body's own alarm system in a chronic pain state isn't always a perfectly reliable narrator of what's actually happening in the tissue. This isn't a reason to override pain recklessly or push through sharp, escalating symptoms. It's a reason to hold listening to your body alongside the broader understanding we've built tonight, rather than treating pain intensity alone as a perfectly accurate gauge of tissue safety. Stretching deserves a similar honest look. For decades, static stretching before activity was recommended almost universally, on the assumption that it reduced injury risk and improved joint health by lengthening tight tissue. More recent research has complicated that picture considerably. Some studies have found static stretching immediately before high-intensity activity may modestly reduce short-term power output, and the broader evidence for stretching alone meaningfully preventing injury or improving long-term joint health is considerably weaker than the confidence with which the advice has traditionally been delivered. This doesn't mean stretching is harmful or useless. Many people find it genuinely comfortable, and it may serve other purposes, including simply helping someone feel more prepared and less anxious before activity, which, given everything we now know about expectation and pain, is not a trivial benefit. It simply means the specific mechanical justification long attached to it that it directly protects joints from injury turns out to be considerably less solid than the confidence with which it was taught for decades. There's also a genetic dimension worth revisiting practically here, tying back to what we discussed earlier. Because a meaningful portion of osteoarthritis risk is inherited, it's worth gently releasing any assumption that a family history of bad knees is simply a story about how carefully or carelessly someone in that family lived. Genetics loads part of the outcome before lifestyle ever gets a chance to weigh in, and knowing that can lift a genuine, if often unspoken, weight of inherited guilt that tends to travel alongside inherited joint pain through families. There's another category of common knee treatment worth examining with the same careful eye: injections. Corticosteroid injections, delivering a concentrated anti-inflammatory directly into the joint, have been used for decades and can provide real, if usually temporary, relief for some patients, though research unrepeated. Long-term use has raised some questions about potential effects on cartilage health that are still being actively studied. Hyaluronic acid injections, sometimes called viscosupplementation, attempt to directly replenish the joint's own lubricating fluid. A logical-sounding idea, given everything we discussed earlier about that fluid's role, though large trials and meta-analyses have produced a genuinely mixed picture, with some finding modest benefit and others finding effects not meaningfully different from placebo. More recently, platelet-rich plasma injections using concentrated components drawn from a patient's own blood in an attempt to stimulate healing have generated considerable enthusiasm, alongside a research base that remains, honestly, still in the process of catching up with that enthusiasm. None of this means these treatments never help any individual patient. Clinical experience and some studies do support benefit in specific circumstances. It simply means that, once again, an appealingly logical mechanism doesn't guarantee a clear universal benefit until it's actually been tested carefully. And the honest answer for any of these options is that it depends considerably on the specific person, the specific joint, and the specific problem. There's a psychological pattern worth naming too, called the fear avoidance model. An ache leads to fear of movement, which leads to avoidance, which leads to deconditioning, weaker muscles, stiffer tissue, which increases pain and reinforces the original fear, a loop that has very little to do with the original injury by the time it's been running for months. And there's a distinction popularized by pain researcher Lorimer Moseley, worth carrying forward specifically: the difference between hurt and harm. In a sensitized joint, movement can genuinely hurt without that movement causing any further damage at all. The two feel identical from the inside, but they are not the same thing. And confusing them is one of the more common, understandable sources of fear around a joint like this. 1. Since we're specifically here at the end of a day, it's worth mentioning one more relationship, because this particular channel has a certain fondness for it. The connection between knee pain and sleep runs in both directions. Poor sleep is associated with heightened next-day pain sensitivity across numerous studies, very likely connected to the same central sensitization we discussed earlier. A poorly rested nervous system appears to turn its amplification dial up rather than down. And chronic knee pain, in turn, is a well-documented disruptor of sleep, particularly for anyone who struggles to find a comfortable position or who wakes stiff after hours without moving. Each side quietly influences the other, which is one small, practical reason attention to sleep itself is so often included as part of a broader approach to managing joint pain. It's worth being concrete for a moment about what all of this tends to mean for the ordinary activities that generate so much quiet worry. Walking, climbing stairs, kneeling, squatting to pick something up off the floor. Each of these has, at some point, been singled out in popular advice as something an aching knee should avoid. And yet each one, examined through the research we've walked through tonight, turns out to be a normal, expected load for a joint built specifically to handle exactly this kind of repeated, everyday demand. Stairs load the knee more than flat walking, certainly, and a knee that's currently sensitized may reasonably feel that difference more acutely. But feeling a difference in mode is not the same as that load causing ongoing harm. Kneeling and squatting move the joint through a larger range of motion and can feel more provocative for the same reason, without that provocation necessarily reflecting tissue damage occurring in real time. None of this is a suggestion to ignore genuinely sharp, escalating, or unusual symptoms, which always deserve proper attention from a professional. It's simply a reminder that the ordinary vocabulary of a life, stairs, floors, chairs, gardens, is not in itself a list of threats to a joint built across millions of years of evolution, precisely to handle this kind of use. It's worth addressing, too, the quiet assumption sitting underneath a great deal of knee-related fear, that aging itself is simply synonymous with decline, and that an aging knee is, by definition, a knee heading in only one direction. The research we've walked through tonight complicates that assumption considerably. Age is genuinely associated with a higher likelihood of certain structural changes, particularly cartilage thinning and the kind of bony changes visible on imaging. But age-related change and functional decline are not the same relationship for every joint or every person. Plenty of people in their 70s and 80s maintain excellent knee function alongside imaging findings that would sound alarming. Read aloud in isolation, while some considerably younger knees struggle despite comparatively unremarkable scans. Age shifts probability. It doesn't write a fixed sentence for any individual joint. There's also something worth saying plainly about the genuine uncertainty running through everything we've covered tonight. The honest admission that researchers still don't fully understand every piece of this puzzle, from exactly why some sensitized nervous systems recover more readily than others, to precisely how durable the newer regenerative treatments will prove over decades rather than years. It would be easy to hear that uncertainty as unsettling, evidence that nobody really knows anything for certain. But there's another way to receive it, one that tends to feel considerably calmer once it settles in. Uncertainty about the fine details is not the same as uncertainty about the big picture. We know with real confidence that the knee is not a static, depleting mechanical part. We know pain is shaped by more than tissue alone. We know movement, in appropriate amounts, tends to help rather than harm. The unresolved details sit on top of that solid foundation, not underneath it, refinements still being worked out, not doubts about whether the foundation itself holds. It's worth mentioning, gently, that this entire picture, biology, history, psychology, expectation, all interacting together, is precisely why modern, well-supported approaches to persistent knee pain increasingly involve more than a single specialist working in isolation. A physiotherapist attending to movement and loading, a physician attending to broader health and, where relevant, medication or injections, and in some cases, a psychologist attending to the fear avoidance patterns and catastrophic thinking that research shows genuinely shape outcomes. Together, these represent a considerably more complete response to the envelope of factors we've spent tonight exploring than any single approach addressing tissue alone ever could. So what do we do with all of this in practical terms? The answer, and this might be the least satisfying part of everything we've explored tonight, is that there is no single answer. Pain in the knee is not a mechanical problem you fix with a wrench. It is a signal, a complex signal shaped by biology, by history, by context, by fear. And like any signal, understanding where it comes from changes how you receive it. For the rest, the different approaches that exist, the strategies that have evidence behind them, the path forward for your particular knee, that is a conversation between you and a professional who can look at your body, hear your story, and guide you. What we've done tonight is not give you the solution. It's give you the words, the framework, the understanding you need to ask better questions and to hear the answers without fear. You're lying there now, in the dark. The same fluid we talked about at the very beginning is still circulating through your knee, slowly, quietly, carried along by whatever small movements your body makes without you noticing. The chondrocytes are still doing their patient work. The sensors inside your ligaments are still reporting faithfully the exact position of a joint you haven't thought about in minutes. Think of everything that joint has carried you through without asking for anything in return. Every staircase, every doorway, every morning, it lowered you gently into a chair. Every night, it held you steady at a sink. Every quiet moment it bent, almost without thought, to pick something up off the floor, or to kneel beside someone, or to reach for something just out of view. None of it required your attention. None of it required a single conscious decision about how the joint should behave. It simply happened underneath the surface of a life being lived, the way breathing happens, the way a heartbeat happens. We started tonight wondering how a joint could bear so much weight, absorb so many years of steps, and still end up so often misunderstood, so often feared. Now you know a little more of why. A monkey dissected in ancient Rome. A ban on human dissection that lasted centuries. A careful physician in Persia, building 600 years of rigorous medicine on top of a foundation nobody thought to question. An X-ray that could only see bone, shaping 100 years of language around a joint it could only half examine. A cushion once thought disposable, removed for decades before anyone checked what happened years later. A crooked tree tied to a straight stake, quietly shaping how an entire field thought about correction and rest. None of it was carelessness. Each generation did the best it could with what it had. And slowly, correction by correction, the picture became more complete, more accurate, and, this part matters most, considerably kinder to the people carrying the joint in question. Somewhere, right now, in a lab or a clinic much like the ones we talked about tonight, someone is still refining this picture further, still testing, still looking a little more closely at what's actually there rather than what's simply assumed. That work doesn't need your attention tonight. It continues whether you're thinking about it or not, the same way your own knee continues its quiet work whether you're thinking about it or not. Your knee is not a hinge wearing down towards some fixed, inevitable failure. It's a living, adapting structure embedded in a nervous system that's doing far more interpretive work than simply relaying damage, capable of responding to what you ask of it in ways far more sophisticated than wear and tear ever suggested. Your knee is still there, still doing its quiet work. The cells are still renewing. The fluid is still circulating. And now you know what that means. Whatever it's been telling you lately, however loud, however persistent it might have sounded, it very likely knows more and is capable of more than the fear around it usually allows for. A scan is a single photograph, not a sentence about the years ahead. An ache isn't always a measure of damage. Sometimes it's simply a nervous system that's been paying a little too much attention for a little too long to a joint that's actually managing rather well. There's nothing that needs deciding tonight, nothing that needs solving in this exact moment. Just a joint and a body and a mind, all three quietly held together in the dark, all three still learning, still adapting, still finding their way toward whatever comes next, without needing you to solve anything before morning. Think, one last time, about that first image from the very beginning of tonight. A thin film of fluid, thinner than a sheet of paper, doing its quiet, continuous work between two living surfaces that have carried you further than either of them will ever be able to tell you. Every hallway, every doorway, every ordinary, forgettable moment of simply standing up and moving somewhere else. All of it made possible by a joint that asked for almost nothing in return across a lifetime, and that is still, right now, asking for almost nothing except a little less fear than it's been given. Somewhere behind your knee right now, blood is still moving through vessels too small to notice, carrying warmth to tissue that's been carrying you all day. Somewhere inside the joint itself, that same slow, quiet lubrication is still doing its work, exactly as it was at the very beginning of tonight, exactly as it will be tomorrow, and the day after that, largely unconcerned with whatever story your mind has been telling about it. The body is not a machine breaking down on a fixed schedule. It's a living, resilient system, quietly negotiating every single moment between what it's asked to do and what it's able to repair. And as you lie there, your body continues its work, quiet, patient, unseen, as it always has.